Let's talk about large intestine motility. So, just to remind you of the anatomy of the large intestine, there are several areas to it. It starts with the ileocecal valve, and then you have the cecum with the appendix in it, and then you have the ascending colon, followed by the transverse colon, and then the descending colon into the sigmoidal colon, and then you have the anal sphincters at the end of it. Interesting to point out that the muscularis externa is concentrated into three bands that are collectively known as the tenai coli, and this runs down the entire length of it. And these contractions generally tend to pull, the contractions of this layer tends to pull the colon into what are known as haustra, which are sort of these sectioned bands that are characteristic of the site of the colon. The anal sphincters, then at the bottom, there's two of them, the internal, which is thickening of smooth muscle, and then the external, which is striated muscle under somatic and therefore voluntary control. So the function of the colon is to move about 500 to 150 mils of luminal content per day, and it is involved in the absorption of water and electrolyte, kind of the final drying out process of the stool before it is passed out. And then as the stool flows through the colon, it's formed and transported into the rectum for final defecation. The motility of the colon is similar to the small intestine, with a couple of poignant changes. It has the segmentation that we saw in the small intestine, but in these cases this is called haustration, as the segments of the colon so characteristic they have been given the name. You also have propulsive peristalsis that is responsible for the orthograde movement of the contents, but you also have anti-propulsion, which is reverse peristalsis, and this allows the colon to retain the stool for longer in it to better aid absorption of electrolytes and water. And then finally you have this mass movement of the colon, which are these large peristaltic movements that flush the colon of their contents. And these happen about 1 to 3 times per day. So here is a barium contrast of the segmentation in the colon. These localized segmented contractions divide the parts of the colon into haustra. And the segmentation, like I've mentioned already, is called haustration. And you can see here there's a segmentation with a contraction after it, segmentation, contraction, segmentation, contraction, segmentation. And this happens all the way around the colon, with the exception of the rectum. And the function of the segmentation is mixing of the content and facilitation of absorption of salts and water. The propulsive peristalsis is concerted contraction of smooth muscle elements, and this empties one haustra into the next one in an arboreal direction. This is the contraction proximal to the stool, and then relaxation distal, that's peristalsis. The anti-propulsion, this happens in the proximal colon mainly, and this just pushes the stool back towards the cecum, and it tends to retain the luminal content in the proximal colon and facilitates extra water and electrolyte absorption. These mass movements that I mentioned are large and longer peristaltic waves that are designed then to push a large amount of stool through a number of haustra, and it empties the proximal colon content into the distal colon and the rectum. The innervation of the colon is both parasympathetic. The vagus nerve extends to the cecum, ascending and transverse colons, and the segmental contractions are influenced by the parasympathetic nerve. And the pelvic nerves from the sacral spinal cord then go to the descending and sigmoid colon, the rectum, and the anal canal, and the stimulation of these creates sustained contractions and expulsive movements to get rid of the stool. Sympathetic innervation generally slows down the contractions and the strength of the contractions. The somatic motor fibers mainly go into the external sphincter, and this then allows you to regulate when and where you defecate. The colonic reflexes are shown here. You have the colonocolonic reflex, which is descension of one segment of the colon elicits a reflex relaxation of the other parts of the colon, and this is a long-range reflex. And then you have the gastrocolic reflex, which is filling of the stomach, increases the motility and frequency of the mass movements of the colon. And then the rectum and the anal canal. The rectum is usually empty, and segmental contractions move contents retrogradely into the sigmoid colon. That is, if stuff is in the rectum and it has nowhere to go, it'll get pushed backwards. And the filling of the rectum is generally by these mass movements that happen 1 to 3 times a day. The anal canal is normally closed due to the constriction of the internal and external sphincters, but fill-in causes transient reflective relaxation of the internal and anal sphincters, internal and external, Fill-in causes relaxation of the internal anal sphincter and constriction of the external sphincter, and this is the urge then to go to the toilet. So defecation is a complex behavior that involves both voluntary and reflex actions. So it starts with the rectum, and you have the defecation reflex where the sacrospinal cord and efferent cholinergic parasympathetic fibers in the pelvic nerves then results in distension of the rectum and relaxation of the external sphincter. So you have this increase in pressure, constriction of the rectum muscles, and then this causes a relaxation of the internal sphincter that allows then the passage of the contents from the rectum through the sphincter. Then the external anal sphincter contracts initially, and this is the urge to defecation, and then if you relax it, the pressure of the rectum then pushes the stool through both sphincters, and this is aided with abdominal contractions to increase the pressure and increase the force. Just want to talk about the disorders related to the motility of the small and large intestines. Mainly want to talk about obstructions and what they do and how you can see them. So obviously an intestinal obstruction causes complete arrest of the flow of contents through the intestine. And a simple obstruction, which is no afference of blood supply, and then you have a strangulating obstruction, which shuts off arterial and venous blood to the bowel section, and this causes an infarction where you can get atrophy, etc. This is kind of what you would see if there was a blockage sort of further down than the small intestine. You see that the small bowel is descended, you've lost the haustrations, you've lost this segmented part, and then you get a backup, so your stomach is filled with fluid, and this is because of a blockage down the bottom end of the colon. Under these conditions, you can see separations of fluids. You have these air fluid levels where the backup, you have fluid backed up because it can't go anywhere, And then if the individual is upright, either sitting or standing, it allows these air pockets to form, and you see these domes that are caused by air that's trapped in the colon and sort of rests above a fluid level within the gastrointestinal tract. And this is the observation of this large bowel obstruction from another direction. This time you have a barium enema, and so you can see that this blockage is only a short way in the large intestine, and I think in this case it was a tumor, and as a result you can see these gas-filled loops within the intestine because gas builds up in there and it has nowhere to go. And these are characteristic signs that you have an intestinal blockage.